of total abdominal injuries. Why you should be taking care of the renal involvement is because the patients may not always present with hematuria. That's the most important. They can present with acute shock also. So we have to evaluate even the absence of hematuria also, whether they had an associated renal injuries. If the patient is having renal damage, the general surgeons don't operate immediately. They will take the case to the urology people. Unless renal kidney system is normal, they don't take up the case. There is a classification is there. What is being followed is called American Association for Surgery of Trauma. Of course, first 2012 it has been modified again. So they have what is called organ injury scaling is there. So this has been described for injuries of all abdominal organs, liver, spleen, kidneys, ureters, mesentery, small bowel, everything that has been described. Let us look for the renal system. So this classification is grade 1, 2, 3, 4, 5. Grade 1 is microscopic hematuria or gross hematuria with a normal renal parameters associated non-expanding subcapsular hematoma. Grade 2 is laceration less than 1 cm with perinephric hematoma. Grade 3 is a laceration with more than 1 cm not involving the PCS. Grade 4 is extending up to the collecting system with a rupture. And grade 5 is shattered kidney. This modified AAST classification is they have brought the shattered kidney, that is a fractured kidney, into grade 4 and shifted the main renal artery renal vein injury to grade 5. In the most of the injuries, renal system injuries, kidney injuries, they are mostly contusions. They what is called non-operating management. So they don't require surgeries. Most of them are contusions and lacerations will be there. Parenchymal distortion, vascular injuries are affected. How do you evaluate? Plain radiograph, CT scan, ultrasonography, angiography, MRI. MRI of course totally not required unless there is some severe contraindication for contrast CT. So most of the time we have to depend only on contrast CT. What is the role of plain radiography in injuries? When there is associated suspected pelvic fractures, then a plain radiography is required. Otherwise, to identify the ureteral or renal injuries, plain X is not required. Ultrasonography is what is being done in the casualties like what fast scan, focus assessment for injuries, for renal injuries. That will tell definitely whether the patient is having renal injury or not. So mostly we will concentrate on CT scan, contrast CT. We made a small study in our hospital. For the last 2 years we have collected the data. Of total abdominal injuries, almost we get 1 or 2 cases of blunt injury in the abdomen, directly coming from casualty, all blunt injuries after ultrasound, whatever the ultrasound findings are there. So we found about 47 cases out of total of 563 cases of abdominal injuries. And renal was involving the kidneys, contusion, laceration of 37, and bladder involvement associated with urethral involvement combined together it was 15 and 6, and 2 cases we had urethral injuries. This is just to give a rough idea what is the importance for renal involvement. When do we have to investigate for CT scan? When there is having any patient with a blunt injury with a gross hematuria, you get a CT. Microscopic hematuria with blood pressure coming down below 90, you have to get investigated. And any patient with a blunt injury with pelvic fractures, always you should get a CT to rule out urethral or bladder injuries. What does it do? Imaging will tell. What is the extent of injury, whether the other kidney is normal or not. Any associated other visceral injuries has to be evaluated. A few examples ultrasound, but this is not very diagnostic to make a final diagnosis for management of the patient. You can see there around the kidneys, a small lucent area, a fluid collection, small subcapsular hematoma. This indicates that patient have some amount of renal involvement. Sometimes hematoma can collect posterior to the kidney, perinephric hematoma. So it may compress on the kidney. Generally, perinephric hematomas will have associated renal injuries. Chain architecture of the kidneys indicates the moment of parenchymal injuries. Sometimes the kidney can be enlarged, shows normal architecture will be distorted. Definitely indicates there is an associated renal involvement. It should be of severe degree. Now let us see all the CT images in different types of renal involvement. The parenchymal contusion type 1 grade 1 injuries. They are ill-defined, irregular and small hypodense areas which may show enhancement with the contrast, delayed enhancement. And only thing you have to differentiate from similar looking lesions like infarcts. Infarcts doesn't enhance with contrast. There is only difference. An example here, small hypodense here in the peripheral part of it, kind of contusion. In the coronal sections, you can see there are multiple or two lesions are there. This is the advantage of doing a multi-size CT. You can take a reformat the images in coronal and sagittal plane. If you have not done this one, you will miss it. Label it as only single injury. Second type, subcapsular hematomas. Small collections and the periphery of between the kidney parenchyma and the capsule. A small collection here like this. This is small subcapsular hemorrhages. The renal parenchyma is totally normal. Third type is perineal hematomas, grade 2 injuries. Lot of fluid collection will be there. So it appears depending on whether the patient presents immediately, the CT is done immediately after trauma or been delayed. So the attenuation will vary. This is a non-contrast CT. There is a controversy whether you should go for a non-contrast CT in all cases. Some people don't follow it, but others, but we follow that all cases should get a plain CT before contrast. Because like in this case, a normal left kidney and right kidney, that a little bit of hyper attenuating area is there. That is a perinephric hematoma. With contrast, there is no function at all on the right side. The perinephric hematoma looks very prominent. Next is parenchymal contusion, grade 2 or 3. Linear low attenuation areas, less than 1 centimeter. Let us see how it looks here. A small hypodense areas here, like these two areas. Contusion, parenchymal laceration here. This patient is having bilateral, two sides it is there. Associated with the liver injury also is there. Next is segmental infarction, grade 4. A sharply demarcated area of absent enhancement. Normal left kidney, lot of hemoperitoneum is there. Upper pole is okay, lower pole well demarcated, no attenuation at all here. A normal right kidney, left kidney well defined here. These will not enhance. So the delayed scan here, there is no enhancement here. This is how you differentiate from a contusion. Parenchymal laceration, next type of grade 4, involving the collecting system. There will be deep laceration with the perinephric fluid collection and increased density on a delayed phase. One or two examples. Normal right kidney, left kidney low attenuation area is here. The delayed scan, there is a 3 times you have to do a CT if possible. You have to take immediate scan within 8 to 10 seconds to identify the renal artery injuries. The next scan has to be repeated again after 40 to 60 seconds to see the parenchymal enhancement. The third scan is to take it after 8 to 15 minutes, that is to see the collecting system, you have to see the ureters and bladder. So 3 times scan has to be done. So this is immediately in the parenchymal stage, low attenuation area, and after 8 minutes you can see the contrast coming out. Urine is coming out here from upper pole here. So this is a deep type of injury. Similar case, the contrast coming along the perinephric area hypertensive area because of injury to the upper calyx. And a different case here, sometimes the perinephric collections can be very bright or low attenuation, whether it is blood or urine. Next is shattered kidney, that is kidney is fractured into multiple pieces. There will be some tissues of viable tissue and some areas of non-functioning. Like in this case, normal right kidney, left kidney is in this place, but lower pole of kidney is not seen there. A large perinephric collection is there. This, since we take the scan, this is multi-cell scans. Let us see how it appears in the next section. As coming from upper pole to lower pole, still a little bit of normal functioning kidney is there. The coronal planes, the lower pole is a little bit. Anteriorly, there is no function is there. Posteriorly, there is no function as you see in the axial sections here. Little bit of viability is there because of some of the branches, interlobar branches are entering the lower pole. After renal, we will go for ureteral injuries. Most of the ureteral injuries are post-surgery, a bad obstacle surgery, hysterectomies, or after some bad surgeries for colon. So, direct injuries to the ureter in blunt injuries are extremely rare because they are retroperitoneal deep in the abdomen. Penetrating injuries, iatrogenic injuries are common. So, how do you identify it? Extravasation contrast from the ureter will be seen. Wherever there is a distally the ureter is there was injury, proximally ureter will be dilated. And a lot of urine collection, urinomas will be there. This AAST classification, standard classification is there, but this is not being followed because it's very difficult to identify the location of ureter and how, whether it is a 50% circumference or less than that. This is not being followed. Common site of uretropelvic junction injuries are important. A deep laceration, large perinephric collection will be there. And most important thing is the contrast will be seen outside the renal parenchyma, but the kidney function will be normal. Like in this case, there is a lot of collections coming here. So the uretropelvic injury, contrast coming to perinephric space. Another example, urine, the contrast leaking out from the ureter. After return is vascular injuries. The percentage of vascular injuries in urinary tract is less. But in this case, what you are seeing is aorta. Left kidney is okay, well functioning. Left side renal artery is okay. Right side renal artery is nothing is seen. It can be artery can be teared, and there can be thrombus formation can be there. So totally no function at all in the right side kidney. Some little bit of enhancement is there. That is because of periureteral vascularity. Sometimes they enter the kidney, or sometimes capsular arteries can enhance. A lot of hemoperitoneum is there. See here, left side is okay, right side again. From here there is no circulation. Sometimes there can be total occlusion because of thrombus, or can be a partial thrombosis also. Right kidney is okay, right renal artery is okay, but left side does no renal artery at all. So total thrombosis of left renal artery. What will you see? Suppose if you see a picture like this one in a coronal plane, normal left kidney, right kidney is totally lost, totally devoid of any vascularity. It can be because of arterial injury or because of venous injury also. What is find here? In this case, the kidney is a little bit lost there. The coronal axial sections here, normal left kidney, aorta. From here, there is no vascularity, but you are seeing some filling defect here. There was a renal vein thrombosis, post-traumatic. It was extending along the IVC also. Renal vein thrombosis as a trauma case is extremely rare. Sometimes it may not be renal artery, parent artery may not be injured, but these small segmental branches can injure. You can see small segmental artery, there is no active bleeding is there. This was a young patient came with a stab injury on the right side of the lumbar region. He came stabbed. Within 1 hour, he came to. We took him for a CT scan. There was active blood was oozing out from the tract. The kidney is enlarged there, totally shattered here. Active bleeding was there. So a lot of blood was bleeding coming from the muscular planes here and from the capsule. The last one is the bladder injuries. Again, AAST classification is there, but it has been modified by urologists. The Society for International Urology has modified it. They made a simple, more practically useful classification. Type 1 only bladder contusion, intraperitoneal rupture, extraperitoneal and combined. Most of them, 85% of the bladder injuries are associated with pelvic fractures. Conventional cystoscopy, that is as I do after IVPs, they are very sensitive at all, equal to sensitivity of CT cystography. Simple case, you are seeing a lot of hematoma in the pelvis, pelvic injury, only clot in the bladder. Conventional cystography showing a large bladder there, fractures in the pelvic bones here. A lot of white areas are there. This is not enhancement, this is the contrast within the peritoneal cavity, intraperitoneal rupture of the bladder. Same thing as it looks on CT. The contrast occurs in the bowel loops. Another case, to see the contrast, this had injury in the pelvis, bladder, lot of clot was there, and all the opacification is around the bowel loops. Typical case of intraperitoneal rupture of the bladder. This was different. You can see a small bladder there, lot of contrast outside the pelvic bones here. You can see the contrast here. You can see in the interstitial spaces here, extending to the perineum also. This patient has interesting point. He's a person working there in the fifth floor, something working, fell down directly on his back. So he had injury to the perineum, very badly injured. So you can wonder what is this area. So we did this procedure, cystogram, CT was done. Then you can see the contrast in the rectum also. So he had developed a bladder injury, extraperitoneal, and also he had injury at the rectum also. So contrast is even coming out into the rectum here, going up into the rectosigmoid. He had a bladder injury associated with a rectal injury. Last one is urethral trauma, then anterior urethral or posterior injuries associated with pelvic fractures, can be partial or incomplete. And the best method of diagnosis is by retrograde ureterography, provided if the catheter is alert. This patient had an injury, so they could not pass the catheter in the casualty. So RG was attempted. There's complete obstruction of the excavation of contrast to incest because of traumatic. This patient came 3 weeks after injury. Suprapubic catheter was done. He was allowed to pass here, he could not pass. So we tried to do RG. The sting stricture is there. It is developed within 3 weeks after injection. CT also can make a diagnosis. You can suspect on CT also. In all cases, obscuration of urogenital diaphragm and hematoma is obscuration of the prostatic compass. These are some of the signs on your CT. You can see a lot of this prostate, hematoma in the ischius cavernous sinus muscle there. Prostatic outlines are indistinct here, some hyperdensities are there. The fractured pelvis there, a lot of hematoma in the stapedial region. So these all indicate the indirect signs of associated urethral injuries. Thank you.